we'll discuss the scientific impact paper number 55 by RCOG, published in September 2017, on the impact of endometrioma, which is endometriotic cysts of the ovaries, and their impact and their treatment, impact of their treatment and their presence on fertility. Endometriosis is a chronic inflammatory process, and it's present in about 6 to 10% of women in the reproductive age group. Obviously, women presenting with fertility issues, the incidence is much higher. Endometriomas, or endometriotic cysts in the ovaries, range between 17 to 44%, and obviously it's associated mostly with moderate to severe disease. There are various theories as to the etiology or pathogenesis of endometriosis and endometriomas, and among various theories, Sampson's retrograde menstruation theory, where endometrium, or the lining of the womb, traveling back down the tube during a menstruation and getting deposited inside the tummy or peritoneum, and the failure of the host immune system to clear the endometrial lining is probably still the mainstay. With regards to endometriotic cysts or endometriomas of the ovary, the ovarian selosa is breached during ovulation, and endometriotic tissue, endometrial tissue, can get impacted and implanted on the ovarian surface, leading to endometriomas. Now, endometriosis and endometriomas do affect fertility and fecundity, and they do reduce fecundity. There is no direct correlation as to the severity of the endometriosis and the symptom of pain. But with regards to fertility, there is a fairly better correlation with the severity of endometriosis leading to decreased fertility. Ovarian endometriomas being associated with more severe disease, therefore, is likely to impact fertility more. There are various ways in which endometriosis as well as endometriomas can impact fertility. They're namely inflammation, changing the anatomy by means of distortion and scarring, impacting on oocyte quality and its function, on embryo quality, on endometrial receptivity and implantation. Specifically, with regards to endometriomas, it generally impacts in three main ways. Inflammation. Endometriosis being an inflammatory process, there has been an increase macrophages, mast cells, natural killer cells, T cells, a change in the growth factors, chemokines and cytokines in the peritoneal fluid, which probably has an impact on oocyte quality and its function. Also, presence of an endometrioma impacts the follicular fluid, and there is an increase in prostaglandins, increased in interleukin-6, and decrease in vascular endothelial growth factors, all leading to an impact on the oocyte function and its ability to fertilize, as well as the embryo quality and its ability to implant. And lastly, just the presence of an endometrioma, and definitely any surgery on it, and in particular if it's bilateral, does decrease ovarian reserve, as correlated with a decrease in AMH, and according to some studies, even an increase in FSH. There is also a decrease in antral follicle count. It may be due to mechanical stretching, as well as due to the inflammation it causes, as well as oxidative stress and free iron, all leading to fibrosis. Now, the presence of endometrioma and the management of it with regards to fertility is controversial. It is always multifactorial, and management therefore should include the woman's age, her ovarian reserve, any previous treatment, particularly surgical treatment, her wishes, and her symptoms into account. Woman looking for spontaneous conception, it has been seen that unilateral endometriomas, observational studies have shown that there is a 43% chance of conceiving naturally within 6 months if there is an unilateral endometrioma, and the affected ovary has an equal chance of ovulation as the other ovary, and there is no difference between surgery or not having surgery with regards to conception within the first 6 months. However, if age is a factor or ovarian reserves is low, then probably IVF should be the first stay. With regards to surgery, if anatomical distortion is a factor, then surgery definitely improves the pregnancy rate. However, if there is no anatomical distortion, just the presence of an endometrioma, particularly unilateral, there is a debate between presence of an endometrioma, which may have an impact on oocyte quality and function, as opposed to surgery, which may decrease ovarian reserve. If surgery is undertaken, it should be done by surgeons who mainly deal with fertility issues, so as to be relatively more conservative. If surgery for endometrioma is done, a cystectomy is definitely better with regards to both preventing recurrence and increasing pregnancy rate, as opposed to drainage and coagulation, and this has been shown in 2 randomized controlled trials. However, observational studies have suggested that drainage and coagulation, particularly if done with less energy devices like carbon dioxide laser or plasma, may have an equal impact as compared to excision of the cyst. However, one has to take into account that any cystectomy does cause a decreased ovarian reserve as measured by AMH. When it comes to IVF, however, the presence of an endometrioma is and its impact is equivocal. Systemic reviews have suggested that the presence of endometriosis, or not having endometriosis, or having unilateral endometriomas, there is probably not much difference. 2 studies, however, have shown that there is a decreased response when there is unilateral endometriomas greater than or equal to 3 centimeters. However, once IVF succeeds, the pregnancy rate, miscarriage rate, and live birth rate are the same. Simon et al. Has suggested that there is an impact on oocyte quality in presence of endometriomas. However, S3 guidelines, which includes a large database and recent studies, suggests that there is no change in pregnancy outcome in presence of endometriomas. When it comes to surgery before IVF, again there is controversy and debate. Systemic reviews, which includes 5 case control studies including 655 patients, suggests that there is no difference in having surgery before IVF with regards to live birth rate, clinical pregnancy rate, or miscarriage rates. Cochrane database, which includes 2 RCTs, suggests that again there is no difference in clinical pregnancy rate when expectant management is compared with surgical management and or with ultrasound guided drainage of the cyst. Meta-analysis suggests the same, and therefore, in summary, S3 guidelines suggest that a cystectomy in unilateral endometriomas greater than equal to 3 centimeters does not change the pregnancy rate or pregnancy outcome, and therefore surgery before IVF should only be considered if due to significant pain, if there is a concern about possible malignancy, or there is difficulty in access to the follicles during egg collection. In reality, however, access to the follicles during egg collection is very rarely a factor, and in fact, surgery can increase more adhesions and cause more difficulty. With regards to the oocyte quality, there is some concern, however, but probably not to that extent as suggested. The chances of malignancy in an endometrioma is extremely rare. The lifetime risk is probably around 1%. And follicle fluid contamination of the egg in presence of an endometrioma during egg collection is also very, very low. Therefore, in summary, ESTRI guidelines suggests that if a woman's age is a factor, there is decreased ovarian reserve, there is bilateral ovarian endometriomas, there is history of previous surgery, and the woman is asymptomatic, then one should go directly for IVF. Only if a woman is significantly symptomatic and there is an unilateral large cyst in a young woman with a normal ovarian reserve, then surgery can be considered before IVF. In summary, surgery does not improve the pregnancy outcome, and therefore one has to individualize the management and have an holistic approach considering this, particularly in view of improved outcomes with IVF. Thank you.